My name is Matt Gondek. I'm a fourth-year medical student, and today I'm going to be presenting a patient case for lumbar instability. So our patient is a 67-year-old female presenting with low back pain that radiated down the left leg. Several days prior to her visit in clinic, she tripped and fell down 3 stairs at home after stumbling on a carpet and, quote, jerking her body. She reports symptom onset immediately after the incident. Her pain is rated at a 4 out of 10 sitting, 6 out of 10 standing, and 6 out of 10 walking. Her pain gets worse with movement and abates somewhat with rest, but not completely. Her pain especially aggravates her at night when she is trying to fall asleep, though it does not wake her from sleep. She states that the pain is worse when she is rolling over in bed and finds it difficult to find a comfortable position. She endorses intermittent tingling in the left foot, but denies any loss of coordination in the left leg. She denies any bowel or bladder dysfunction. She denies any symptoms in the right leg. She has been taking ibuprofen with some relief of her symptoms. She also applies heat packs in the morning and ice packs at night, though these have given her minimal relief. This is not her first episode of back pain. She started with a work injury in December of 2007 that resulted in similar symptoms, which somewhat resolved with activity modification and chiropractic treatment. She's had several exacerbations over the years, all of which seem to resolve with chiropractic treatment and conservative measures. In the past, she's had electrostimulation, she's used a TENS unit, and she was previously on narcotic pain medications, but has not been for some years. Until this most recent exacerbation, she had not been required treatment in the chiropractic clinic for about 5 years. She was able to continue working as a developmental aide for some time until retiring in 2011. For her past medical history, she's otherwise healthy and takes no medications on a daily basis, though she does take a multivitamin. Surgical history includes bilateral knee replacements, the left in 2010, the right in 2011. She is currently retired and lives at home independently. She's a non-smoker and has no drug allergies. For the physical exam, she is a 5'4" Caucasian female, weighed 221 pounds. Her blood pressure on this visit was 140/74. Her musculoskeletal exam, her postural evaluation revealed a low right shoulder and low right hip. On her gait examination, she has no obvious gait deficits, is able to heel walk and toe walk without difficulty, and she can perform a 1/2 squat, though this reproduces her low back pain symptoms. For her range of motion in the lumbar spine, she can flex to 24 degrees, extend to 15 degrees, left lateral bend to 13 degrees, and right lateral bend to 17 degrees, though these are all with pain with the exception of the right lateral bending. On her straight leg test, she can raise her left leg to 48 degrees with lower back pain radiating to the left ankle, and on the right side can raise to 58 degrees, but also has pain radiating to the left ankle. For her strength examination, she has 5 out of 5 strength in the right lower extremity, including all the psoas, quadriceps, hamstrings, tibialis anterior, and gastrocnemius muscles. She is 4 out of 5 in the left flexor hallucis and left extensor hallucis, 5 out of 5 in the left psoas, quadriceps, hamstrings, tibialis anterior, and gastrocnemius. On her physical performance examination, she had force measurements done and showed a 7% hip extension deficit on the right side, a 10.8% deficit for hip flexion on the left side, 8.4% deficit for hallux extension on the left side, and 9.6 deficit for hallux flexion on the right side. On palpation, she had muscle spasm noted over the lumbosacral region, and palpation reproduced the pain she was having in bilateral lumbosacral regions. Deep palpation produced the reported pain radiating to the left buttock. On her neurologic exam, her cranial nerves 2 through 12 were all within normal limits. She had a 1 out of 4 patellar reflex bilaterally and an absent Achilles reflex bilaterally. Her sensation was intact to light touch on upper and lower extremities bilaterally. She also had electromyography studies done, which showed normal distal motor conduction latencies of the right and left tibial and peroneal nerves, though there were abnormal amplitudes of the left tibial nerve with compound motor action potentials. She had normal F responses of the right and left tibial and peroneal nerves, a normal distal sensory peak latency of the right and left superficial and sural nerves. She had abnormal tibial nerve H reflexes with an absent response on the left side. She had an abnormal needle EMG in the left lower limb and left lumbar paraspinal muscles, for an overall impression of an active left S1 radiculopathy, with no evidence of focal lower extremity entrapment neuropathy, lumbosacral plexopathy, lower extremity peripheral polyneuropathy, or myopathy being observed. Moving on to her imaging findings, we'll start with her MRI images. On the screen we have T2 weighted MRI images. On the left is a midline sagittal view, and on the right is an axial cut through the L1, L2 disc space. As you see, there is a bilobed bulge of the annulus with facet arthropathy. There is mild retrolesthesis and mild secondary canal stenosis. On figure 2 is also a T2 weighted MRI image, and as previously, the left is the midline sagittal view, though on the right, now we have an axial cut through the L2, L3 disc space. There is a bilobe bulge of the annulus with facet arthropathy as above. The canal is at the lower limits of normal, but not acutely stenosed. There is mild bilateral foraminal encroachment by the annulus bulging. In figure 3 is a T2 weighted MRI image with a sagittal view of the left lateral recess on the left side of the screen. On the right side of the screen is an axial view through the L3, L4 disc space. There is a broad bulge of the annulus with marked facet arthropathy. There is moderate secondary stenosis, and there is bilateral foraminal encroachment with subtle contact of the left nerve root visible on the left lateral recess image. Figure 4 is the T2 image with a sagittal view through the right lateral recess and an axial view again through the L3, L4 disc space. What's different on figure 4 is you can see the minimal effect that the stenosis is having on the right L3 nerve root. It is less significant than compared to the left L3 nerve root. Figure 5 is a T2 weighted MRI image with the sagittal view through the left lateral recess and an axial view through the L4, L5 disc space. There is a broad bulge of the annulus with marked facet arthropathy and severe secondary stenosis. You can see what's called the trefoil effect on the axial cut on the right side. The trefoil effect is occurring on the cauda equina and results in what you can see as the triangular shaped appearance with a projection at the bottom of the triangle. There is stenosis of the lateral recesses bilaterally. As you can see, the left lateral recess on this image, you can see there's bilateral inferior foraminal encroachment, though on this image there's no obvious effacement of the left L4 nerve root. Figure 6 is the same L4, L5 disc space on the right with a sagittal view of the right lateral recess on the left-hand side. Again, you see the broad bulge of the annulus with facet arthropathy and the severe stenosis. There is mild effacement of the undersurface of the right L4 nerve root that you can see on the sagittal view. Figure 7 is a T2 weighted MRI image with a sagittal view of the right lateral recess and an axial cut through the L5 to S1 disc space. There is a broad bulge of the annulus with an asymmetric right lateral component, which you can see best on the axial view. There is facet arthropathy. There is no canal stenosis at this level. There is encroachment upon the right foramen with stenosis and compression of the right L5 nerve root. In addition to her MRI, we also obtained flexion extension X-rays from a lateral view. Figure 8 is the flexion view, which shows mild anterior wedging of the vertebral bodies of T10 and T11. There are multi-level spondylitic changes with end plate spurring, anterior bridging osteophytes, and disc space narrowing. There is an anterolisthesis of L4 over L5, measured at 10.06 millimeters and measured for you on the image. For comparison, the extension radiograph is figure 9. As you can see, because we measured it for you, the anterolisthesis seen on the flexion imaging partially corrects, is now 5.1 millimeters as compared to the 10 millimeters it was on flexion imaging. Which brings us to our differential diagnosis. Based on her symptoms that are worse with movement, and she's had several of these episodes over the years, which all seem to more or less resolve with treatment conservatively, the degenerative changes seen on her MRI images, and the amount of translational effect she has at L4, L5 on her flexion extension imaging, it makes her most likely diagnosed as lumbar instability, more specifically the anatomic subtype. We'll get into the criteria to make that diagnosis in just a bit, but for the rest of her differential diagnosis, she does have some spinal stenosis seen on her MRI images, though none are at the S1 nerve root where she's had the radiculopathy on her EMG. And the rest of the differential would include muscle spasm, disc herniations. She doesn't have any compression fractures on the imaging, and she doesn't have any red flag symptoms such as those for cauda-equina syndrome or anything suggestive that she would have an epidural abscess if you were working in the ER. So her official diagnosis is anatomic lumbar instability with radiculopathy, confirmed on flexion extension radiographs. As far as her treatment goes, as in the past, she was largely treated conservatively. After this latest incident, she was treated with chiropractic adjustments, including a long axis rapid traction, which decompressed her spine and provided prompt relief of her symptoms. She was continuing to use heat packs and ice packs at home, as well as taking ibuprofen as needed. She will continue to follow up with the chiropractor on an as-needed basis and will monitor her symptoms. Given the amount of instability on her flexion extension radiographs, had her symptoms not abated, she would possibly benefit from having spinal fusion surgery once all conservative options were exhausted. So for the discussion, like many patients with back pain, her initial picture is relatively nonspecific on the surface. She doesn't have any of the red flag symptoms for cauda-equina or epidural abscess, so we rely on the rest of her history, physical testing, and imaging to tease out the more specific cause for her pain. One would expect, given her left-sided S1 radiculopathy, based on her symptoms and confirmed by the EMG study, she would have more impressive imaging findings at that site on the MRI. However, her MRI images showed a lot of overall degeneration, but really nothing specific at the left S1 site. Though there was some nerve root compression on several levels on both sides, as well as some overall canal stenosis, which could contribute to her radiculopathy symptoms. The flexion extension radiographs add more to her story and help us confirm the diagnosis. As we discussed, on her flexion study, she has a 10 millimeter anterolisthesis at L4, L5, while on the extension view, she corrects somewhat to 5.1 millimeters. This means that overall there's a 4.9 millimeter translational effect at the L4, L5 level that changes when she moves from flexion to extension. This amount of translational effect meets the criteria for the diagnosis of anatomic lumbar stability, also known as radiographic or structural lumbar instability. You might see those referenced in the literature. The criteria historically for this diagnosis are as follows: a sagittal plane translation of 4.5 millimeters or more, or 15% of the vertebral body. or rotation upon the vertebral body of 15 degrees at L1, L2, L2, L3, or L3, L4, which increases to 20 degrees to make the diagnosis at L4, L5, and 25 degrees at L5, S1. Though there is new literature coming out which are pointing towards a much lower threshold to make that diagnosis. The most recent studies show as little as 2.3 or 1.6 millimeters of translation is enough to cause the symptoms of instability. On resting images, the criteria to make the diagnosis would be a 4.5 millimeter anterolisthesis, or 15% displacement in the sagittal plane, or angulation on the sagittal plane of 22 degrees or more. Lumbar instability is generally defined as a significant decrease in the capacity of the stabilizing system of the spine to maintain the intervertebral neutral zones within the physiologic limits so that there is no neurologic dysfunction, no major deformity, and no incapacitating pain. Essentially, instability results from a failure of one of the three stabilization subsystems of the spine: passive, active, and neuromuscular. The passive subsystem is the bones, discs, and ligaments in the spine that all keep things from stretching too far. The active subsystem is the muscles and tendons that provide stability for the spine, including the multifidus muscles, the transverse abdominis, internal obliques, quadratus lumborum, the psoas muscles, as well as the erector spinae muscle group. Last but not least is the neuromuscular component, which is the central nervous system, the peripheral nervous system, including the receptors and pathways of proprioception. This third subsystem uses the proprioceptive data and load sensation to coordinate the musculature and keep everything aligned for us. Lumbar instability largely comes in two flavors: anatomic, which we have been describing above, and functional instability, where patients have these similar symptoms but simply do not meet the criteria for anatomic instability on the flexion extension imaging. When a patient doesn't meet the radiologic criteria, there are several clinical tests that can be used to make the diagnosis. These tests are somewhat controversial as they have varying sensitivities and specificities, and they're difficult to validate because if the patient doesn't meet the radiologic criteria for the diagnosis, then there's no gold standard test to look for to make the diagnosis of functional instability. Our patient had several risk factors for lumbar instability, including the degenerative changes seen on her MRI, including spondylolisthesis, disc degeneration, facet arthropathy, as well as other risk factors like being of the female gender, she's obese, she worked in an occupation that required a lot of lifting, as well as the history of the traumatic injury given the recent fall. While she did not previously carry the diagnosis of instability, it's plausible that it had a hand in her previous back injuries, and many patients with instability have a history of recurrent back pain before they ever diagnosed. They often report the sensation of their back slipping out with certain motions, or catching when they stand from the flexion of the spine. Their pain is often worse with certain movements, as our patient complained that the pain was worse with rolling over in bed and certain movements around the house. Treatment measures for instability center around the most conservative of measures at first. She was already treated by the chiropractor, as she had been after previous episodes. She was taking her ibuprofen as needed and continued to use ice packs and heat packs to control symptoms at home. Other options for her, if she needed them, would include lumbar stabilization exercises, which is a program whereby the patient is trained to increase the strength of the stabilizing muscles and to improve motor control as well as proprioception. This training program has been shown to improve symptoms from lumbar instability and increase muscle strength and proprioception, balance out some of the structural instability. Patients have also reported fewer recurrences of back pain after completing one of these programs. As a last resort, spinal fusion surgery is often utilized in the cases of anatomic instability, especially in patients with her level of anterolisthesis. Many patients report improved symptoms after spinal surgery, though there is conflicting data on whether the surgical patients do better than patients who did strictly the conservative measures, though it's certainly reasonable that after they exhaust conservative measures to offer a patient surgery. Overall, lumbar instability, especially the functional aspect of it, is an evolving area of medicine. There's a need for further studies to improve diagnostic measures and to achieve some consensus on clinical testing when the radiographic findings are unremarkable.